Okay. Good afternoon, everybody. It is Saturday, January 19th. I usually jump onto these live sessions every now and then just to go over different topics of the spine. Uh, Many people, usually this number gets up to a couple thousand, know my background, but just as a reminder for those just jumping in, I'm a spine surgeon here in Dallas, Texas. I usually jump on these live sessions just to kind of answer various anatomy questions, general spine questions. Can't give any advice. But in general, I always start off with like a lumbar spine model and try to just show people different aspects of the spine that kind of help make sense and show people what we're talking about when you have back pain, you have spine surgery, and then I'm going to go over different topics on that. So again, my background here in Dallas, Texas, this isn't a marketing or ad thing for me. I just like to jump on this and go over different topics for people and just kind of answer some questions. So it goes bone, disc, bone, disc. The lumbar spine, I say usually, has 5 vertebral bodies. And under each thing called a pedicle, it's almost like the column holding the bone up, are these nerve roots coming out. Different nerve roots go to different parts of the body. Most people have, when you have issues, you have it at the L4, L5, L5, S1, and that's what's coming down and squeezing nerve roots that kind of cause the numbness and tingling going down. So that's kind of what you hear. That's the issue you might hear about in spine surgery, spine issues. Okay, so with that being said, let's go over the 3 reasons why most people have disc herniations, or, well, let me say that differently. There's usually 3 reasons why people have pinched nerves in the spine. Number 1 could be from a degenerative arthritis where these bones are rubbing on the joints. These bones start to get thick, the joints start to get thick, and they pinch the nerve, numbness and tingling down. Number 2 is a medical word called spondylolisthesis. That's when one of these bones slips forward on the other and the rest are stable. And that dragging, moving back and forth of the nerves decreases the disc space, pulls the nerve. And the third type, why you could get something called spinal stenosis or a pinched nerve, could be just from the sheer loss of this disc height here, or a disc herniation that pushes out and squeezes the nerve. So a disc herniation that pushes out can hit the nerve, numbness and tingling down. The other thing that can happen is the spondylolisthesis. That's when one bone's moving on the other. And the third thing that can cause the pinched nerve would be the degenerative arthritis in the joints. All 3 of those things can pinch the nerve, squeeze the nerve, cause different issues with spinal stenosis, pinched nerves in the spine. So let me get to a couple questions that are coming in. One from OSO, L45, modic type 1 marrow signal. Well, there's 3 types of modic changes. Essentially, it's a type of MRI finding. I think it's named after probably Dr. Modic. I think it was at the Cleveland Clinic. I have to go look at that again. But essentially, it's a way to identify different spine issues on MRI in terms of bone bruising and signal edema. Not to get too technical, but there's kind of 2 types of MRI sequences. There's a T1 and a T2. For the most part, you look at T2s as a spine surgeon, but based on how the bone lights up or does not light up on T1 versus T2 is kind of how you define type 1, type 2, type 3. It is thought that probably type 1 progresses into type 2. Usually it's thought that type 1 is more associated with back pain. By the time you get to type 2, you still have back pain, but type 1 can be more indicative of back pain. A little debate in that, and there's not, some people just have increased modic changes in their spine and don't have back pain. So don't have all the answers there on that. Again, appreciate the questions coming through. Appreciate the comments. I'll try to get to those. Again, can't give advice. Spine surgeon here in Dallas, Texas. And we'll go from that. From Jeff, I had lumbar laminectomy. I'll move my mouse here. Lumbar laminectomy. If fails now, doctor wants to use a Coflex and steel. Is this good? Gosh, there's so much to break down on that comment. I would be surprised if they want to do a Coflex after a laminectomy. Usually, like my thoughts on Coflex aside, usually when you do the laminectomy, you do a Coflex. I guess if you have a laminectomy that fails, I guess I would want to know what failure means. Is that because these foramen are still too tight? Is that you have a current stenosis? Is that because you have back pain? I guess what does failure mean in that setting? Is this like 5 years later? Is it 5 weeks later? Is it 5 days later? So that's also part of it. Okay, so not to get too technical here, but if you have a laminectomy and then like 3 years later, maybe 8 months later, you still have some residual stenosis in the nerve roots, you could go back and try to open up, try to rotor-rooter those nerve roots again. Many times, though, it's actually not that common to need this, believe it or not. If you actually get a fusion, a which I know you're not too excited about a fusion, but hear me out. It's almost like you get this spacer, this disc spacer here that opens it up. It opens up the nerve tunnels. And it looks just like this. So imagine this spine model here. I wish I had one of those more degenerative, but if you lost the disc height and it was pinching down, squeezing that nerve, by putting in a spacer here, it might open it up and might open up that nerve tunnel. That's how after a laminectomy surgery, you might need a fusion surgery. That'd kind of be the goal of that. Nerve being pinched from Jeff. Jeff, I sometimes recommend, again, I can't give any specific advice on your case. I don't know anything about your case, but if I do a laminectomy on someone and they're still having some numbness and tingling, things like that, I think doing an epidural steroid injection, specifically a transforaminal one, putting a needle right next to that nerve. Spine doctors can do them. Pain doctors usually do them. That's another pretty good, darn reliable way to kind of calm it down even more at that point. Let me kind of get to some other comments here. I'm going to scroll through. There's a lot of things going on here. Let me get to some questions, read some of these things here. Yeah, I don't know who that doctor is, Jeff. I'm sure they're great. Look, let me get to something people ask a lot about, and I have a lot of mixed feelings on this topic. But this right here is a 2-level lumbar disc replacement model where it goes bone, disc replacement, bone, disc replacement. A 2-level lumbar disc replacement is actually not terribly common. Usually patients are not candidates for a disc replacement, and then they are candidates for disc replacement. Usually it's just 1 level that's needed. Sometimes if it's 2, maybe it's a fusion, then a disc replacement. There's a whole lot of things kind of go over that in just such a short time span. But essentially, here's how these lumbar disc replacements work. If this is a 1 level, you can see there's a metal frame that kind of helps attach to the bone, and there's different substances that can go in the middle. On this one here, it's called PEEK. It's a very fancy medical word for a medical grade plastic. How about that? It's like polyethylene, an E word, and ketone, and it just helps kind of rub here. It's a frictionless or low friction surface. That's just a good option sometimes in a very narrow set of patients with degenerative disc disease that have failed conservative treatment options. I love disc replacements for the neck. A little mixed feelings about the spine sometimes, but for the neck, they're pretty good. From Jeff, set at my age, 68, no fusion, just Coflex. I don't know. 68 I've used hundreds of people that are 68. Jeff, I think that's pretty young. Maybe I can't tell if they're saying that you're old or young when you're saying 68. I think you're pretty young. But kind of moving on from that. Well, let me get to a couple other models here. This one here is pretty interesting. I always have a hard time disassembling this one. Oh, don't worry about that noise. Okay, well, I think that's my problem. I can never get this part to detach. All right, well, I'm not going to break it on live TV. Okay, so let's go over what a laminectomy is. So a laminectomy is a spine surgery procedure that spine surgeons do all the time. It's on the back part of the spine. The incision can be the size of your thumbnail or the size of a credit card. Kind of just depends on how many levels, how big the patient is. But the way it works is it goes bone, disc space, bone, disc space. And on the back part of the spine, so it's on your back, on the back part of your spine, usually lumbar spine, this blue part here, not this one here, but this blue part here would be removed. And then the spine surgeon, like myself, would get into this area and clean out the arthritis. So again, here's a more real looking spine model in a way. It's this part of the bone here. You get inside here with special tools, clean out the degenerative arthritis that's in there, the thickened tissue, the thickened wear and tear. It's a great way to fix spinal stenosis is really the end of the day what it's called. Spinal stenosis is what's fixed with that. Let me see if I can put this back together now. Again, appreciate the questions, comments coming in. I will upload this live stream to, oh, now it comes off, of course, now that I get it. Great. From Lori, I don't know the answer to your question. I'm sorry. I don't actually know what that is. I have to look that up, but interesting term. From Wayne, getting ready for an ALIF L5S1. Already had fusions at 3, 4, 4, 5. That's exactly what I'm playing with right here in my hand. This is an ALIF cage, ALIF. The key thing about all these cages, not just this one in particular, almost all of them, some of them are not this way, but pretty much almost all of them, is the front part of the cage is fat. The reason that you want that front part fat, the back part skinny or smaller, it's like a wedge shape. So it helps curve the patient back, something called lordosis. So if you ever see any spine model or see any pictures of the spine or anything like that, if this is the spine down here, you curve the spine back. Why is that important? Well, you want to walk around in the world with your shoulders and head kind of over your pelvis. Otherwise, you're leaning forward all the time. How do you fix that? You fire your back muscles in the back. By firing your back muscles in the back, that's what's causing your back. That's one of the many, many reasons that can be causing your back pain is if you don't have that curvature of your spine. So say you have degenerative disc disease at multiple levels, you're wearing out, wearing out, wearing out, wearing out. Okay. So now what do? You will bend your knees, bend your hips back, and you try to kick your spine back. That's flexing these muscles. That's pulling all these muscles all day right here. That's one of the many sources of back pain is just firing those muscles all day because of the degenerative disc disease and your body's compensating so that your head can be up looking at a normal horizon. So in spine surgery, one of the reasons we might do a fusion, one of the reasons we might use, or likely, hopefully, use one of these cages that's bigger in the front, smaller in the back, is to help restore lumbar lordosis. You put those spacers in here, not at every level. Maybe, most surgeries are, if they're fusions, are 1 levels and 2 levels, every now and then 3 levels, every now and then T10 to the pelvis. My goodness, those are really indicated when the patient's totally collapsed forward or if they're scoliotic from like a sideways, almost like a snake looking x-ray. But putting those cages in, just going back to your question there, Wayne, is why we would, if this is where you're living your life, helps curve you back. That hopefully helps decrease the rate of additional surgeries, additional back pain is using these more high tech, these hyperlordotic cages where they're really big in the front, skinnier in the back, and they curve your spine back. And that's just a newer understanding in terms of spine care. In fact, just the whole concept, it's called pelvic parameters, is something that us spine surgeons they weren't even really truly defined like 15 years ago. They weren't really even being taught 10 years ago at all places, but there's a bunch of different numbers and patients sometimes see me in the office and I'm measuring things on their x-rays and I say, sorry, this is really boring, but I like to measure these on almost all my x-rays, if I'm doing a fusion surgery, something like that. And then, I'd probably say 100% of the time the patient says, don't worry about it, take as much time as you need, which it's definitely the right answer. I mean, they're never gonna be like, no, hurry up, I want to know. That's why sometimes when you're waiting on the doctor, those are the things that are taking a while. As the surgeons, you want to do it once and do it right. And so I spend a lot of time during those visits really planning out the surgery because that's in a way the best you're ever going to remember the patient, know the patient. So you want to measure out everything. You want to use specific type of spacers, specific type of cages that kind of curve the spine back, that open it up in the front, a little more narrow in the back, and they help restore the lumbar lordosis in the spine. It's a big part about spine surgery. Okay, so let's jump to a couple more questions we got here from Wanda. She says, correction of L4, anterior of L4, L5 with spondylitis. I'm guessing that's talking about what surgery you're getting. Okay, I see. Sorry. So you had a question above. Doctor, are you able to share with consent patients who you have worked on regarding their experience? Yeah, actually, Wanda, if you go onto any of my platforms, I have a lot of patient testimonial videos and it shows their face and everything like that. And, with their permission, they were so happy. In fact, a lot of them found me through social media platforms. And so they said, oh, I'd love to help tell others about the good aspects of spine surgery at times. And so can we make a video? So those are usually those patients who do that. It's a lot of work and a lot of time to make those videos, but it's definitely helpful. So I do have those. If it's something where every now and then a patient who's booked for surgery with me, I will connect them with another patient they maybe remind me with if they're having issues with just being scared about surgery or things like that. But that is something I definitely do fairly often as I connect patients. They can talk. There's, to be fair, I've never had spine surgery myself. So there might be things on post-op day 5 and 6 when you're nice, comfortable at home that I've never thought of. And the patients can kind of talk to each other and just share different things that they did in anticipation of surgery, after surgery. So I definitely connect people all the time. I wouldn't say all the time, actually. I'd probably say once every other month, just because most people want to be connected, need to be connected. But when it comes up, I do definitely do that, is the long answer long to your question. Okay, so Bradley, Bradley Bailey, I'm a physical therapist. How early do you allow dry needling for soft tissue restrictions after fusion, laminectomy, or discectomy? Bradley, I'd kind of be okay with that pretty early, like at the very latest, 6 weeks after. But I'd be comfortable with a patient going back to dry needling as long as you stay away from the incision sites. The incision's not, depends what it is. Maybe it's this black part of the pin. It's right in the middle. Most of their muscular pains can be pretty off lateral on either way, maybe 4 or 5 inches either way. So I'd say just kind of isolate your dry needling over to that side. But I wouldn't have too big of an issue with it. I actually encourage them to get dry needling all the time. Pilly, how are you? Good to talk to you. Is there a surgeon perspective? Is there a difference? The outcome, grade 2 versus grade 3 spondylolisthesis? The long answer short is no. Uh, kind of same outcomes, honestly, 2 versus 3. Usually, if it's 2 versus 3, that means you're going to be needing a fusion. If it's a grade 1, you could probably get by without a fusion. So, in terms of your outcome, if you can avoid a fusion, great. It's just frequently people shouldn't avoid a fusion. People maybe are looking to avoid a fusion, but the fusion is going to be better for them. And there's just different argument there. Just once you get to 2, 3, if it's unstable, like a fusion's way better. Grade 1, it's a little debated. And, I've made a whole career on not fusing stable, degenerative, grade 1 spondylolisthesis. That's like a mouthful of medical words. Each of them makes sense. So that might be something I have to kind of explain over. I've gone from 1 to 2 in the space in 2 years. Is that inches? That's probably a lot. I don't know if that's 100% right. Maybe millimeters, but then there's so much discrepancy. I don't know. I can't comment too much on that, Pilly. It's just tough to say. Let me get to Ibrahim's question. Can vertebral fused patients perform high intensity workouts at the gym? Oh yeah, for sure. If you get and look, there's different fusions. There's neck fusions, thoracic fusions, lumbar fusions. There's different fusions that could occur that have different outcomes. So in general, let me just do a couple things here. In general, we have different types of fusions we're doing. I would argue that one doctor told me at 65 they should retire. I don't know what that means. Oh, that's a different question. In general, if you have a neck fusion, 1 or 2 levels, I'm not going to restrict you on anything you want to do, kind of ever. If you have a 1 or even 2 level lumbar fusion, I'm not going to really restrict you to do anything you want to do. I want you to go back to doing the things you like to do. That's kind of why we're doing it, honestly. Okay, let me do one more thing here. Just get this going live. Okay, but yes, after a 1 level, 2 level spinal fusion, I let patients go back to most things they like to do. Let's go over the recovery from a spinal fusion. Now, again, there's cervical fusion, thoracic fusion, and there's also the reason why you had the fusion. Patients are different. I have to do fusions on some people that are 40 years old, which I think is really young. Some people that are 60, 70. There's also some people I've either this week or next week, she's 93 and I have to do a 1 level neck fusion on her. And I think I say that right. I have to do it. I'm pretty busy. I don't need to operate on 90-year-old patients, but it's such severe spinal cord compression that it's something where she's falling, the balance is off. It's a medical term called cervical myelopathy, pretty darn common. So let's go to a couple other questions. We got about 40 lined up here, and so I'm trying to get to them. Get back to Ibrahim's question. What complications do the patients face after surgery? Well, that's a whole variety of answers there. Let me kind of get to some of the more common ones, and they're all about 5%. There's a 5% rate of getting a blood clot in the leg, blood clot in the lung, 5% rate of infection. Again, these vary. If I'm doing something called a microdiscectomy, that's an incision about the size of my thumbnail, those risks are way lower. If you're doing a bigger surgery, 1 to 2 level spinal fusion, 3 level spinal fusion, then the risks are different. Probably once a month, I do a big deformity surgery. Those aren't surgeries I'm itching to do. They're all day surgeries. I'm really tired after. They hurt my back, hurt my neck. But those are up to the thoracic spine. So I kind of say right where your bra line is, if you wear a bra every now and then, all the way down into the pelvis. The incision's huge. To put it in context, let's see what is a universal size here of something. Okay, if this is like a mouse, it's like 5 times, maybe 3 times the size of a mouse, all the way up here. That's a T10 to pelvis surgery fusion. So big deal surgery. So the risks from that surgery are definitely way bigger. All right, let me get to a couple questions here. I got Dorio. Dorio, your question is mostly in Spanish, but I see most of it in terms of what's a laminectomy. So a laminectomy, I apologize for those who are streaming on the other platforms because I know we just went over this, but doing this really quickly, a laminectomy is a back of the spine, so posterior spine surgery. Can be on the neck, but usually when it's in the neck, you need to do a fusion. A little more on that in a minute. On the lower back, just different bones, different anatomy. You do not need to do a fusion. So let me kind of come back to that. It's almost like in hip surgery and knee surgery. You might have the same type of surgery in a way, but they're like totally different, right? It's the hip versus the knee. Same thing with doing surgery on the neck versus the lumbar spine. Even though it's spine surgery, even though it's kind of similar, they're kind of way different in terms of doing neck surgery versus lower back surgery. The bones are different. Doing a laminectomy on the neck usually should be associated with a fusion just because the structure, the anatomy, the muscles kind of on the back. It's something that we learned this very well back in the 80s and 90s that if you just do laminectomies on the back of the neck, you get something called drop neck where your neck kind of comes down like this. You just lose the structure. That's why we've also created procedures called laminoplasties, different than laminectomy, but that's for the neck, or laminectomy with fusion. Whole different argument. On the lower back, lumbar spine, different story. You can do the laminectomy surgery. You can do it from L1 to S1 really without destabilizing the spine if you kind of just stay within the rules, stay within the guidelines of not taking too much bone. The majority of laminectomies are probably 2-level laminectomies, maybe 4-5, 5-1, maybe up a little higher at times. And doing that, you don't need to do a fusion just because you're doing a laminectomy. Incision that big, and then going back to the spine model here that kind of shows it. You remove this blue part of the spine right here. You get in there with your tools, you clean out this area, you can kind of see where my finger is right there. And that's how through the back part of the spine, I use this ultrasonic bone scalpel. It's pretty nice and fancy, but I don't really have the time to talk about that right now. And then you can see if this is the nerve tunnel coming out from the back part of the spine, I can get in here and fix the nerve tunnel. Open the nerve tunnel for pinched nerves. You get the pinched nerves from degenerative arthritis, the bones rubbing on each other, growing. Let me go over one more topic. There's 3 reasons someone can get a pinched nerve. Let me say that differently. There's 3 of the most common reasons why someone could get a pinched nerve. One is from a disc herniation, where if this is the side view of the spine, you get a disc that pushes out, squeezes the nerve. Number 2 is from these joints getting a degenerative arthritis, or they're rubbing, they grow extra tissue, just like a callus formation on your hand. That thickened extra tissue starts pinching a nerve, numbness and tingling running down. And then number 3 most common reason is a degenerative condition or a fracture of the spine, but you get this instability where one bone is slipping forward on the other. That's something called spondylolisthesis. Now, are there other reasons besides those 3? Yes. You could get a trauma. You could get a burst fracture. You can get infection. You can get a tumor. You can get malplaced hardware. You can get post-op hematoma. There's other reasons you can get a pinched nerve in your spine besides those first 3. But those first 3, I'd assume, cover 90-95% of why most people get pinched nerves in the spine. Degenerative arthritis, genetics, this micro trauma from hyperextension that creates a fracture in the back part of the spine. My favorite thing to treat. And then you get this instability where one bone is slipping forward on the other. One bone is slipping forward on the other. Those are the 3 reasons most people get pinched nerves in the spine. So that being said, let me try to get some questions here on our other platform going on. I see, golly, so many people in the chat right now. I'm trying to get to all these. From NASLYGIS. What's the management for posterior medial nerve compression L1 to L5 in a patient with pain and some dysthesia in the inferior part of the knee? That's a lot of. I think the main thing you got to do figure out what your diagnosis is. Even just reading that was kind of a mouthful and like probably true, but not exactly what's causing your pain. If you have arthritis from L1 to L5 and it's going to the medial part of the knee, like that all might be true. But if you're having arthritis in your back, it's probably causing your back pain. If you have some arthritis pinching one nerve, it's causing that. So it's probably not all the arthritis from L1 to L5. Not to get too complex or confusing there, but it sounds like you just need to get to the bottom of exactly what's your issue. Is it the back pain? Is it the numbness on the inside of the knee? The way you can do that is an exam, is an MRI. You can see which nerve kind of correlates to the map pattern of where the nerves go in the leg, in the back, down the back of the thigh, down the butt, all the way down into the foot. And then usually a spine surgeon can be the quarterback, and they can direct with different steroid injections, maybe targeting one or two of those nerve roots, targeting one or two of those facet joints, and just seeing what's causing what the response is. If you have a great response, then that's it. If it doesn't work, well, maybe that's not where your symptoms are coming from, so it shouldn't work. And we get to a couple of other questions here. I'll try to do rapid fire. They're coming in pretty fast. I do apologize. I see some people are frustrated. Having another question, I apologize. My surgeon is 70 years old. Is he? No, 70 years. Okay. Sorry, I'm just reading them as they're coming in. If your doctor is 70 years old, he's not too old at all. I am suffering with severe stenosis. Do you think an epidural injection benefits me from Lissy? Probably. Just because your MRI says severe doesn't mean you have to have injection, doesn't mean you have to have surgery, doesn't mean you have to even be treated. There's many people that have a radiology reading of severe, or even me looking at it being like, that looks severe, but you're not that symptomatic. Or we do a little anti-inflammatory and like you're good for a good while, maybe forever. So I wouldn't just focus on the MRI findings or even when the surgeon's saying it's severe. It's more on the clinical symptoms. From Braden, what autograft do you use for fusion? Okay, not to get too technical, but there's a difference between autograft and allograft. Autograft means it's coming from the patient's own body, and most spine surgeons use either the patient's own bone spurs. We grind them up. If you're doing a fusion or something called a TLIF, you're taking out the joint here, you grind that up. That's the autograft. Back in the day, and still some people still do it, we used to harvest. I don't have it on this model, but you had a pelvic and your hip crest. We would make an incision, we spine surgeons, on either the front part or back part, and then take bone from your hip crest. That's still good and great in terms of getting some good bone, but it has at least a 33% chronic pain rate just from taking that bone graft. So fortunately, with science or whatever we want to say it is, we've created better bone graft substitutes. So we don't necessarily need to take it from the patient's crest because that hurts. It'd be really dumb to do a spine surgery, fix the neck, fix the back, and then create some hip pain or kind of pelvic crest pain. So that's autograft. Then allograft, ALLO graft, is essentially synthetic bone. And that's a wide spectrum. It could be cadaver bone. It could be ceramic substitutes. It could be demineralized bone matrix. So there's just a whole lot of things that fall into the allograft category. It's not all cadaver bone. The one I like the most, I'm not going to say its name because I'm not trying to give advertisement to it, but it's like a ceramic composite. So it's almost like this ground glass. It has this chemical called, or mineral, I don't really know, hydroxyapatite. It's got calcium crystals in it, and it's a synthetic bone. And then it has, I think there's some bovine collagen in it, pig collagen. There's a ton of them. There's probably 50 different types out there that are all different ceramic alloy, ceramic composites. I really like those. I think those really help extend the patient's own bone that I harvest into a longer fusion mass. Sorry, I was reading some of these questions from Braden, you got some good questions. T-lift, O-lift, P-lift, what's your typical approach? All right, you know what you're talking about. Well, a T-lift, I think I'm good at. I just hate doing them. My training was very T-lift heavy. Some people go through training and don't ever do a T-lift. And those at home are like, what's a T-lift? Stop saying a word I don't know. Okay. A T-lift is where you use a smaller cage, actually, a cage about this big, to put in perspective. If this and this hand here, this is my left hand. I don't know if you're seeing it at home is left or right, but so like if this is an A-lift cage, look how big and fat this cage is. These two cages, two totally different ones, are different PLIF or T-lift cages. If you're like, what are these fancy words you're saying? They make no sense. Essentially, it's talking about the approach, how you put those cages in. Do you go through the belly, which is great? Do you go from the side, or do you go from the back? T-lift, T-L-I-F, or PLIF, P-L-I-F, or replace these smaller cages from the back. The reason they're smaller is because you have to kind of pull the thecal sac to the side. You have to pull the nerves to the side to get those cages in. And at home, you might be like, well, is that good? Is that bad? Do I want you to pull those nerves to the side? There's just different pros and cons of different ways. Some people, I like going through the belly, but some people are like, oh my God, I don't want to go through the belly. That's my guts. That's my intestines. There's vena cava aorta for sure. I'm not downplaying that, but you have a vascular surgeon helps you not totally risk-free, but the big advantage of going through the belly is you can get these bigger cages in. These are big, and you might then at home be thinking, why do I want a bigger cage? Does that matter? Is bigger better? Like, shouldn't I want a small, cute little thing in there? Not necessarily. The bigger the cage, you get a bigger footprint covering this part of the bone. So there's less risk of the cage just pushing through the bone. There's less subsidence. You can also get a higher height. You can get more height to open that nerve tunnel even more. You can get more lordosis, more curvature of the spine back. So that's a big deal in terms of the bigger cage. But there's downsides. One of the downsides is you need an approach surgeon if you go through the belly. You need a vascular surgeon to go for the belly. And you might be like, why is that a downside? Well, it depends on where you live. It depends on the doctor's relationships with vascular surgeons and just if they even do those there. But I have some friends who work at big university hospitals, and their vascular surgeon is also doing different procedures, shunts, stents, and they're not just at the surgeon's call to come there and help them expose and get there. It financially maybe doesn't make sense for the vascular surgeon to take time out of their day to go do that. And then maybe from an institutional standpoint, that's just hard. Maybe they have residents and fellows with them, and now the residents exposing down there, the fellows closing, maybe it just takes forever. And there's all these other people coming in. So maybe at a big university academic center, you don't want to do that. That's how ours was in training. It's like, dude, going through the front took forever because we had to rely on the residents, the fellows, and the attending to do it. Now in private practice, my goodness, we have vascular surgeons. That's all they do. They drive around town and they just, maybe 5 or 6 cases a day, get us there and then leave. They might get me to this front part of the spine. No joke. 9 minutes after we say cut. They're so skilled, so good. It's almost like building a Ford car back in the day in this assembly line. They know exactly what they're doing. Either way, I'm getting a little off track here, but that's why some people might not do anterior approaches, is they just don't have the institutional resources to go through the belly. You don't have a vascular surgeon. They don't have the time or the financial support from the institution to do that. Therefore, a posterior approach is also great. There's also risk going through the front. There's some people I don't want to go through the front on, and so I will do it from the back. Now, I did say going from the side. That can be, going back to your question, an OLIF, an oblique approach. It can also be a lateral approach. Here's 2 different lateral cages, and these are totally different looking. Look at these. See how these are long? I don't know what these look like. You guys tell me at home. What do you guys think these look like? You might just say they look like lateral cages, but look at the size difference of these two versus this big one. Sorry, I don't have 3 hands. Versus this here, or this pliff cage. Look, the difference of these is they can go into the side, under the ribs, above the hip, but very hard, almost impossible to do that at L5S1 because your hip crest is here. You can't get to it. And then depending on the patient's anatomy, some you can't get to it at L4-5. And those that you could get to it at L4-5, maybe their psoas muscle. There's a muscle you have to go through. It's just so far forward. It's just a little too risky. You don't want to do it. At L1, L2, not a common level to need fusion or surgery on, but then 2, 3, 3, 4, oh yeah, lateral surgery all day for sure. Love it there. In fact, I don't like going through the belly at those levels because I almost want to save the belly surgery for 4-5 and 5-1. In fact, if they have a 4-5 issue, I'd rather go from the side so that I could save that anterior going through the front for an ALIF in the future. So going back to your really good question, Braden, that's what I'm thinking about in terms of how do I get the cage in there? Once you've established they need surgery, then you establish, do they need a fusion? And then you establish, well, how am I doing that fusion? Am I going through the front, going through the side, or going from the back to get that cage in? That is the long answer, Braden, to how do I pick my approach. In my dream perfect world, I do ALIFs, so cage in the front, and then bring in the O-arm from Medtronic, do a spin, a CT machine, and then I use my augmented reality headset, make a small slit incision. Really, it's small, not trying to brag. I mean, anyone can do it that small. Place my 4 screws, 1 rod, done. 1 level 360 ALIFs, percutaneous posterior spinal instrumentation is great. And why is it great? Well, it's just such a powerful surgery with very well recognized, well managed risk and very well recognized and reproducible outcomes. Is a great way to think about an ALIF with posterior spinal instrumentation in the right hands with the right vascular surgeon with a spine surgeon that does that procedure all the time, with the technology, navigation. You don't have to with navigation. With augmented reality, you don't have to with augmented reality. But there's just a whole lot of ways to think about it and ways to go about it. So, but some people don't need it at 5'1". They need a surgery somewhere else. Some people don't need a fusion. So even though it's great, doesn't mean I do it all the time. From Wanda, does a previous appendectomy prohibit an anterior approach? No, it does not. There's not too many things that ever limit an anterior approach, but that is definitely vascular surgeon or approach surgeon dependent. The one I use, my goodness, I showed her one. I knew what she was gonna say. Actually, that was one I wasn't sure. The guy had a prior stomach cancer, and he showed me this picture of his post-op picture like 5 years before of a big old incision on his belly. It was a little hard to see when I saw it 5 years later. And he said they had to open up his belly and do all this stuff, but like his pathology was so good for an L5S1 ALIF, and she looked at it and was like, "Yeah, no problem. Let me look at his imaging, and for sure." So, uh, radiation is a big is a relative contraindication from going through the front. Used to be if you went through the front once, you shouldn't go through the front again. That's actually not 100% true. Usually they, I know it looks like the front, but they can go from the left side or the right side. They might just do the other side the other time. Believe it or not, I don't think I've had to do any revision going through the fronts for like an elective surgery. I think usually I just maybe don't think it's worth the risk, and I'll just go from the side or the back, or it's a different level. It would have to be, I don't know, just case dependent. I just haven't had to do it yet. Okay, let me get some other things here. Okay, I got a comment here from, I'm not going to say the name out loud for HIPAA reasons, but you guys can read the comment. But it says, I'm a patient of Dr. Donnelly. Great doc. No surgery for me yet. Anti-inflammatory meds helped. Okay, appreciate the nice comment. Good friend from Space Ghost. How does osteoporosis affect your ability to use screws with such surgery? It's a huge deal. In fact, if I'm suspicious or if I'm doing a fusion on certain people over the age of maybe 65, I'm going to see if they've had a DEXA, a bone density study, or I'm going to order one, and then we'll go forward from there. If they have normal bone density, then great. If they have terrible bone density, then maybe I try to talk them out of a fusion, which you're like, sounds easy. And to be fair, it is. We just do a laminectomy. Or it's like, man, they really need a fusion surgery. Okay, let's see if we can manage the pain temporarily. Try to buy 3 months, 6 months, 1 year, and we start some bone strengthening medications to strengthen their bones so that they could tolerate the fusion. Because for real, there's not too many things intraoperatively during the surgery that I'm ever worried about, concerned about, keeps me up at night. There's not too many intra-op things that ever can go wrong. It's the post-op stuff that keeps me up at night. It's the post-op stuff that makes me lose my hair. It's the post-op stuff that just is emotionally draining on spine surgeons because we care about our patients. We get to know them. We get to know their family. And the post-op stuff is infection, pain, spinal fluid leaks, nerve pain, the screws cutting out, just as you said, in osteoporosis. But even not in osteoporosis, the screws can kind of just wear out from micro motion. So those are definitely the risk of surgery I think about. And those are the ones that I try to tell patients all the time. Like during the surgery, you're going to do great. I'm going to come out. I'm going to say everything went great. It's the after. It's the 2 hours after. It's the 2 days after. It's the 2 weeks after. It's the 2 months after is what I'm thinking about whenever I talk to any patient about surgery. There's no one I'm not thinking about that on. From Braden, can you explain where you place your screws for a PARS repair? Man, Braden, what's your background? You're asking some in-depth questions. Well, look, usually for a direct PARS repair, which I don't do too many of those anymore, but you try to place them almost like a lag screw technique. It sounds like you have some background where you try to lag this bone fragment back in there. For probably 99% at home are like, what are you talking about? But if you have a PARS fracture and you're outside of your adolescent period and it needs a fusion surgery, then I just do a traditional transpedicular approach. You have to really fit a narrow subset, like high school athlete, maybe collegiate athlete, but you're probably too old by the time you're in college to get a direct PARS repair. It just has a pretty decent failure rate. Not that that's not worth trying, but there's just David Skaggs is someone I think super highly of. He has a lot of videos on this concept. So if that's something affecting you, or just go search David Skaggs direct PARS repair on YouTube. I bet you'll find his videos. What is the golden age of a patient? Why operate on an okay, can I just start over? Why operate on an old age patient? Because they need surgery. You know, I'm not trying to operate on, it'd be great if I only operate on people under 64 years old, right? Like half joking, but that's when people start to wear out and start to need surgeries and maybe even start to need bigger surgeries when they get into their 60s, 70s, sometimes 80s. Just maybe our bodies weren't meant to last that long. And fortunately, we have spine surgeons out there that kind of reverse arthritis and reverse father time on your spine. So that's why I operate on old age patients. I'm not, not trying to operate on old age patients, but there's been two times at least my anesthesiologist essentially said, no, that patient's too old. And unless I said I really, really, really wanted to, like 7 times, but yeah, why operate on old age patients? Because they need surgery sometimes. And if it's not me, then who is it going to be? And sometimes I like the patient too much to let someone else try to fix them when I think I could do a pretty safe, ethical, good job on it. All right, I'm gonna do a couple more questions and then I do have to run. Got my kiddo here napping, so I'm checking on him, but I'm probably gonna go inside and do a couple things before he wakes back up. So from Wanda, I submitted all my documentation to your office and I look forward to consultation. Thanks, Rhonda. Wanda, sorry, Wanda, I'm gonna type in an email address. Just reach out to this email address. And that's one. I don't want this to be a marketing thing, but that email address there is you can email my lead scheduler. She kind of works specifically for this exact purpose of people reaching out on this platform. I'm not trying to have this be an ad or anything like that. But in terms of telemedicines, things like that, that's something I do all the time, many, many times, and would love to have the honor of taking care of you. And you can see I have many patients here. Okay, let me kind of see if there's a couple more questions here. I apologize for missing some of these questions. They're coming through fast. From moving with Jimmy on an L5S1 fusion, is it safer to do all through the back, even though it will extend the recovery? I don't know if safer is the better word because there's just different risk of going front and back versus all from the back. So I would argue if it was me, I would, and I needed, and I had a pathology that warranted a lift going through the front surgery as a spine surgeon. If I was able to operate myself and or if I had the vascular surgeon or if I could pick the surgeon, I would want them to go through the front and from the back if I had a pathology at L4-5 or L5-S1. Um, but that might not be applicable to you. So don't take my advice on that. If your surgeon doesn't go through the belly a lot, don't tell them, hey, I want you to go through my belly because some doctor online said so. Like, that's ridiculous. It's just in my community in Dallas, we just have such good vascular surgeons and anterior approach surgeons that go through the belly all day, every day. It's just fast and reproducible. It's not the fast part that matters, honestly. I keep saying that, but it's just reproducible and sufficient, and patients do really well from it. And then you need the back part also. So I know it sounds crazy. It's like, if you do it all from the back, why are you doing why are you doing front and back? Well, I've kind of exhausted those reasons at length. So you can kind of rewind this video back and I can tell you the advantages of going from the front and from the back. But there's just a big advantage there. So from Rick, what's the email for my scheduler? I just typed it right there. I'll type it again. But for those listening, I don't know if you guys can see the comment box or not. I don't exactly know how that works, but it's the word spine. So everyone can write this down if you want. Again, I don't want this to be marketing for me, but it's spine, SPINE, at tscspine.com. Texas Spine Consultants, tscspine.com. But I don't want this to be an ad for anything. So let me go through one more thing, and I really do got to run. I know I keep saying that. I see one, man, that's a really good name. Jay Jones. Where do you see robotics, NAVs, and AR in the next 5 years? Do you see it benefiting spine surgeons in the future? Well, it only sounds like a really smart person could ask that question, but let me think about the smart answer for that. So I just got to ask a really good question. It said, where do I see robotics or technology or navigation in spine surgery in the next 5 years? I think it's going to be a critical part. Right now, we use spine surgery robots essentially only in spinal fusion cases, mostly in lumbar fusion cases. It would be great if we could find more applications for the robots to help us do non-fusions, to help us do disc replacements, to help us do frame anatomies, decompressions. In fact, it'd be great if we can use the augmented reality or if we can use the navigation to help us with endoscopic surgery or decompression surgeries. Right now, a lot of our technology is focused on the fusions, which are definitely needed, and there's definitely a role for those in the majority of patients. But there's definitely a subset of patients that just need a small decompression surgery. It'd be great if we can use some of these $1 million robots that we've made to help us have better accuracy, better efficiency, and smaller incisions in some of this robotic technology that keeps coming out every year. So that's a great question from that probably is one of the most sought after reps in the nation, I'm guessing. And that's really good. So with that, everybody, I see some other questions coming in. I do apologize for not getting those, but I could do this all day, but I'm not going to do this all day. And so with that, I am going to go. I'm going to close out here, and I appreciate any of the follows and subscriptions.